welcome to BIOTRONIK Live webinar. My name is Joanne and I will be your host for today. The speaker for today is no stranger to you. He is Dr. Gary Lee, consultant cardiologist and electrophysiologist from Thomson Hospital, Kota Damansara. We are pleased to have him with us this evening to share with you about closed loop stimulation.
Hi, good evening to all my fellow colleagues. Yes, thanks to BIOTRONIK for bringing us this platform to be able to talk on something that's something fairly close to many of us about closed loop stimulation. So basically, the next half an hour or so, what I'm going to intend to do is to talk about the open loop rate adaptive pacing and also closed loop stimulation itself. Basically talking about CLS usage in AF and visual syncope and also a case illustration to take home the message as well. So I've always known, pacemaker has always been a device whereby it is something that allows us to pace the patient whenever they suffer from any bradyarrhythmia. But what is very important for pacemaker is that this ability to have rate responsive aspect of it. Meaning to say that if patient requires any form of pacing increment in terms of the rate itself, this device, this intelligent device, should be able to adapt to it. And as we know, the old conventional pacemakers are usually based on what we call physical or physiological indicators that works around the algorithms within the pacemaker itself that allows it to increase the pacing rate for patients whenever it needed. But these indicators are usually non-physiologic, like vibration or acceleration, and also can be physiological, like in terms of our minute ventilations and our QT intervals. And this is the usual mechanism that has been applied in conventional pacemakers that allows the pacemaker to be rate responsive. So whenever you have patient with sick sinus syndrome or sinonodal dysfunction, the fact that this pacemaker is able to increase the pacing rate whenever it is needed physiologically by the body is because of based on these indicators that feedback into the algorithm that sits within the pacemaker's device itself. So the core aspect or core reasons behind it actually because of these piezoelectric crystals that actually whenever there's any mechanical stress along it, it will actually generate voltages and output. These voltages output will then actually be placed into as an input to the pacemaker or to the pulse generator itself, and of course generate various different output based on the activities. For instance, if you are sitting, the output generated by these piezoelectric crystals will be fairly low in amplitudes and frequency. But if you're going to walk, you're going to do running itself, then these amplitudes and the frequency will increase because of the amount of mechanical stress to these piezoelectric crystals has changed itself. So these voltages will then be feedback into the algorithm within the pulse generator and generate a pacing rate increment as well. But then we do know that whenever the piezoelectric crystals are glued to the inside of the can, the sheer fact of just touching the pacemaker can itself, or pressing of it or lying on top of it may actually generate all these voltage changes and lead to unnecessary or inappropriate pacing rate increment. So that is why people have modified the crystals to be actually not in contact with the can anymore, but rather sit within the core of the pulse generator itself. And the same concept also is whenever there's any mechanical stress that has changed the crystals within the can itself, and this will generate differences in output and of course feedback into the algorithm within the pacemaker and generate increment of the pacing rate as well. Then of course, if we look at the physiological indicators or physiological input to the pacemaker can to tell us or to tell the pacemaker when to increase the pacing rate, we can look at minute ventilation itself. If you realize that the pacemaker generator over here actually constantly sends some what we call subthreshold impulses to the leads itself, and this will actually allow the pacemaker to measure the impedance itself. And this is actually what we call transthoracic impedance. If you look at minute ventilation, it basically boils into two very important components. One is the tidal volume, how deep you breathe, and of course the respiratory rate, how fast you breathe. The tidal volume itself will actually translate into the amplitude of the transthoracic impedance being measured by this pacemaker can itself that is constantly sending sub-threshold signals to the leads itself. And of course, the frequency of this impedance, the transthoracic impedance, will then also reflect the respiratory rate. So the amplitude and the frequency of this transthoracic impedance, which is within the can of the pacemaker and the lead itself, will actually feed back to the pulse generator, telling you how fast this patient is breathing. And of course, if you are someone who is doing exercises, for instance, you find that the respiratory rate will go up, the depth of breathing also will increase, and this will also translate to the minute ventilation as an input to the pulse generator, leading to increment of pacing rate as well. So this is again, of course, one of the method or one of physiological input to the pulse generator that allows the pacing rate to be increased based on patient's needs. Because mind you, most of these patients we are implanting a pacemaker who had sinonodal dysfunction, they cannot increase the pacing rate itself without all these physiological or non-physiological input. Of course, the other form of physiological inputs that we can actually utilize is actually based on the QT intervals. We know that as our heart rate becomes faster, the QT intervals actually shortens. So the device itself is actually able to sort of measure constantly behind the background itself within the steam itself to the QT intervals. So this is really a steam to T intervals. So the shorter your steam to T intervals, then this device is going to tell, they're going to set in the algorithm and say, you know, increase the pacing rate as well. So of course, if you look at this so-called open loop stimulation, which is actually utilizing non-physiologic or mechanical indicators or physiologic or metabolic indicators, utilize these both indicators to fit into the pulse generator algorithm and tell them how fast will you pace, should you increase the pacing rate or should you not. But there are actually pros and cons between using both of these indicators or what we call open loop system. Of course, if you look at mechanical indicators, for instance, accelerometers or activity sensors, it is very fast responding. The moment you shake the body or the moment you start moving around, these accelerometer within the body itself, within the pulse generator, will be able to sense the patient is moving. I need to increase my pacing rate. It is fast, but unfortunately, it's very low in specific. For instance, if patients are just on a vibratory massage chair, then that will actually be sensed by the device. This patient is running, but in actual fact, patient is not running. So it gives you a false positive incidences. Whereas if you rely on physiologic or metabolic indicators, for instance, minute ventilation, despite being very specific, you know, as patients are doing more exercises, the depth of breathing will increase, the breathing rate also will increase, but unfortunately, it's a bit slow in response, so it may not be able to cope. So you will find that patient in the initial phase of their increment of physical activities, the pacing rate still remains fairly dampened down, so it doesn't commensurate with the needs of the body itself. So what it does is, in open loop system, in most conventional pacemaker, they combine both of these non-physiologic indicators and physiologic indicators and make it a more perfect form of system to utilize in terms of rate responsive in a patient with sinonodal dysfunction that requires a pacemaker. So what it does is, as illustrated in this next screen here, you realize that when patients start having exercises itself, all right, just at the beginning, this is a pacing base rate, which most of the time we set about 50 to 60 beats per minute, all right? So whenever the patient starts exercising itself, the first indicators that would increase or will trigger the increment of pacing rate will usually be by the non-physiologic. It means by the accelerometer or the sensors activity. So then it will increase the pacing rate. But as the physical exertion continues on, there's only a set amount or fixed amount of movement that is being picked up by the accelerometer or the sensor activities. Therefore, it will come to a plateau whereby the pacing rate will not increase further. Then that's when physiologic indicators like minute ventilations will come in and try to increase more the pacing rate as the patient continues on with the physical activities, as illustrated in this graph over here. Then you will realize that the pacing rate will actually continue to increase, but it's actually being triggered by the physiological indicators. So both non-physiologic and physiological indicators work hand in hand together to increase the pacing rate in a conventional, which is usually an open loop pacemaker system. Of course, having said that, this is far from being perfect. Despite this has been used for decades already, this open loop system. it's far from being perfect because there are still loopholes whereby when patient needs an increment of pacing rate, it doesn't happen. And this is why BIOTRONIK has comes in with a new system called closed loop stimulation. It's not a very new technology per se, but it has been around, and this concept has been explored in many contexts as well. One of the very important usage of closed loop stimulation is, of course, in terms of mental stress. We know that in normal humans, whenever there's any mental stresses that comes in, the autonomic nervous system, which is of course the sympathetic, will overdrive the whole context itself. And you'll find that patient's heart rate will go up, blood pressures will go up, and of course, needless to say, every sympathetic stimulation will go up at the same time. But unfortunately, if you were to have patient with sinus nodal dysfunction, this is something that is lacking. Whenever there are mental stresses, the conventional pacemaker that utilize open loop stimulation cannot increase the pacing rate appropriately. That's the most lacking part in terms of the open loop system. Whereas the closed loop stimulation is trying to overcome this so-called loophole and close the loop per se. And of course, this is why we're going to explore a bit in the next few slides. Therefore, it's really trying to mimic the physiological response of our body, a native physiological response in terms of any form of stresses, be it physical stresses in terms of physical exertion or in terms of mental stresses as well. So this is really what it utilizes in terms of heart rate as well as contractility. I'm going to show to you over here in these slides over here. You realize that in most patients who are normal with normal functioning sinus node, intact nervous systems, whenever the physical activities comes about, or whenever there's any mental stresses comes about, the autonomic nervous system will then trigger increased contractility of the myocardium. This leads to increased inotropic effect. At the same time, it's going to send signals to our sinus nodes and increase the pacing rate of our heartbeat. This is chronotropic effect as well. So in most patients, these are the fairly intact forms of autonomic nervous system feedback mechanism. But unfortunately, for patients with sinus nodal dysfunctions, the feedback in terms of chronotropic arm is not functioning at all because the fact that the sinus node has become dysfunction. Whereas what we do see is that the myocardium part, the contractility part, still remains intact, and the autonomic nervous system can still increase the contractility of our myocardium based on the physical stresses input or because of the mental stresses input. But the one which is lacking will be the chronotropic arm itself, whereby the autonomic nervous system is not able to stimulate the SA node to increase the heart rate itself. That's why patients who are actually implanted with the pacemakers with closed loop system, as in this context, we're talking about BIOTRONIK closed loop system, you realize that it is trying to close the loop over here and bypassing the abnormal or the dysfunction sinus node. Therefore, utilizing the autonomic nervous system itself, which still can send inputs towards the myocardial contractility, and whenever the myocardial contractility changes, there will be changes in a localized impedance of the RV muscle mass itself. And this RV muscle mass impedance change will then be picked up and utilized in this BIOTRONIK CLS pacemaker system to replace the native chronotropic arm input from the autonomic system, and therefore leading to increased heart rate. So you're really utilizing this CLS to close the loop itself to ensure that whenever you have physical stresses or mechanical physical stresses or mental stresses, you're still able to increase the contractility of the myocardium, at the same time increase the heart rate of it, utilizing the CLS system. So of course, then people will be wondering, how does this happen? Well, the same context also, whereby the pacemaker itself, the CLS pacemakers will also be sending what we call subthreshold pulses from the pacemaker can to the lead itself. Subthreshold pulses means it's actually a pulse that is in microamperes itself that doesn't capture the myocardium, but it allows the pacemaker to measure the impedance of the myocardium itself. And this is how it goes on. And it always sends a couple of subthreshold pulses in different variable forms of amplitude itself. So have a look at this, the next slide itself, sort of understand the gist of what CLS really utilize the myocardial contractility. In a patient who is in a relaxed mode or pre-ejection itself, the area that is in contact with the lead is actually lesser. So therefore, the impedance is lower down. But when your heart contractility increases, for instance, you are physically stressed or mentally stressed, then the area that is in contact with the lead tip itself becomes increased. And therefore, it translates into higher impedance. And this high impedance itself will be utilized by the CLS pacemaker to adjust the pacing rate. So this is more physiological in that context. So as I illustrate in this few slides over here, you realize that this is at rest where the lead and the myocardial interface has what we call a baseline impedance value. And this will be recorded by the device at background without needing any forms of intervention from the user or end user itself. But as the contractility increases, then you find that there will be change in the impedance curve itself. Impedance will go up. As they continue to send all these subcortical impulses, it will continue to monitor the changes in the localized RV muscle mass impedance. So as more and more activities are being up, all right, and more myocardial are actually being recruited in the contractility itself, the impedance will go higher and higher. And of course, at the end of the day, what the device does is it has its baseline graph itself. Whenever they begin to sense there are more changes in the impedance, then that will translate, because they're going to compare the baseline graph that has been plotted all the time through with the increment of the contractility graph. Then if there are more and more differences, the pacing rate then will be adjusted based on the patient's indication. So utilizing this, it means that if someone has mental stresses or physical stresses in terms of physical activities, the myocardial that has been recruited in the contraction itself will be increased, will translate to more high impedance, and this will then be plotted in the graph and compared to the baseline graph, and this will tell the device, I have to pace the patient faster in that context. So of course, there are some CLS specific characteristics that can be changed by the end user itself. For instance, we will not want patients who is at rest to be stimulated or to have increment of pacing rate to be very high itself. So this is something that we can actually adjust. But most of the time, we leave it at default setting. And of course, again, we also can adjust the CLS response in terms of how sensitive we want this CLS response to be. For instance, if you have someone who is very sensitive, very anxious, then you may want to dampen down the CLS response. Because remember, mental stresses will lead to increment of sympathetic drive, and that will lead to increments of myocardial contractility, and that will translate to increments of RV impedance. Then that will lead to CLS response, increasing the pacing rate. So if someone who is very anxious, someone who is overly OCD and things like that, you may want to dampen down the CLS response. So this interface allows you to sort of change a bit of the response based on your patient's needs and of course your patient characteristics. So having said that, so I hope at the end of the day, you do understand the idea that the CLS algorithm that is being utilized by the BIOTRONIK pacemakers is actually trying to increase and improve the rate responsive adaptive pacing of a pacemaker to a patient's needs, so that not just only movement itself will translate to pacing rate increment as we see in open loop system, but even what we call mental stresses itself has also been utilized as one of the input that will translate to increment of pacing rate in a CLS pacemakers itself. So having said that, and people will always wonder, would actually this CLS be really utilized in real life itself? What will be the outcomes, or how will be the clinical experience like? So in these studies that is almost about 9 years or 8 years old already, you do realize that this is about registry that's about 700 odds of patients, over 57 sites in Europe and in Hong Kong itself. And they actually look at the physicians' feedbacks in terms of utilizing CLS enabled pacemakers and whether they actually have satisfactory performance itself. And you can see across the board, most of the satisfactory performance are above 80%, irrespective of where you put the pacing lead itself, whether you put it in the apex, whether you put it in the septum or so forth. Because some people do believe if you put the pacing lead near the septum, whether you're talking about low septum, mid septum, and so forth, you tend to have a better response rate. But again, in this registry, you do not see much differences. or whether you're talking about patients who had heart failure to begin with or without heart failure to begin with. So overall, in real clinical experience, you do see that CLS is fairly pacemaker, which allows you to see a very good satisfactory response for patients itself in terms of symptoms improvement. And of course, if you have a look at this itself, one of these papers does show to you the shaded area, the shaded columns over here, that whether you're at rest, whether you're having mental stresses itself, only the CLS-enabled pacemaker will be able to have increment of pacing rate more appropriately based on the physiological response rather than the conventional open loop stimulation pacemaker that is available in most of the other devices. And of course, just sort of sum up, only the CLS, if you look at this bar on the top over here, the graph that is plotted, you can see that whenever you do a physical activities, the pacing rate will go up, and that will of course translate to increment of cardiac output. But at the same time, when you have mental stresses, only the CLS-enabled pacemaker will also increase the pacing rate, at the same time more appropriately increasing the blood pressure itself, hand in hand increasing the cardiac output, which is needed by most of the patients. But when you have patients who actually utilize the open loop stimulation as illustrated at the lower graph over here, you do find that physical activities, yes, they do very well. But in terms of mental stresses or mental inputs that requires similarly increment of pacing rate, similarly increment of this cardiac output, you will find that it's actually dampened down. So it doesn't really translate to good utilization of a rate responsive. So you may end up with a patient who actually had an implant of a pacemaker with the open loop stimulation. They may end up suffering from inadequate cardiac output, and because of the pacing rate doesn't increase based on their physiological need. Whereas the CLS patients or CLS pacemaker implanted patient, they tend to have more near physiological responses in terms of pacing rate increment based on the physiological responses and need. So having said that, we already sort of go through the CLS concept, the CLS being used in real clinical setting itself. So how do we utilize CLS pacemakers? There are many settings that we can utilize, but I'm just going to dwell on basically two. In terms of patients with sinus nodal dysfunction, with concomitant atrial tachyarrhythmia, CLS has a very good usage in it. And of course, the other one will be CLS pacemaker usage in vasovagal syncope. So this is something that I'm going to dwell on. So if you have a look at this, patient with closed loop stimulation in atrial fibrillations, we do know that, I'm sure many of you have heard before, some of the papers actually even come out and has been shared to many of us actually, talking about rectal or digital rectal stimulation actually terminates atrial fibrillation. There's a real concept behind this because we do see that before patients start having paroxysm of atrial fibrillation, there's actually a surge of sympathetic overdrive. And this sympathetic overdrive itself will actually translate to increased cardiac contractility. And this will increase the RV impedance, and again will be picked up by the CLS pacemaker. And whenever this CLS pacemaker has picked up this increasement of this RV myocardium impedance, it's going to preempt and going to increase the pacing rate. So this is sort of trying to overdrive it in a way before the AF or any form of atrial tachyarrhythmia sets in. So you're really trying to prevent the occurrences of atrial fibrillation. And that's how CLS actually utilize its algorithm in trying to use it in patients with sinus nodal dysfunction, who most of the time also end up with a lot of atrial tachyarrhythmia as well. So this is why CLS tends to work better as compared to those pacemakers with open loop stimulation, which really has no role in terms of prevention of recurrence or occurrences of AF in a patient with sinus nodal dysfunction. So then this actually brings us to two important studies of utilizing CLS pacemakers in atrial fibrillation. One will be the burden 1 study and of course a burden 2 study. Both are fairly similar concept whereby you have patients who are actually being randomized to a CLS-enabled programming. Overdrive atrial pacing. The overdrive atrial pacing, the concept is that if you pace the atrium faster than it should, you would suppress the triggering of an atrial fibrillation. And of course, the conventional DDDR pacemaker programming itself. But you do see that at the end of the day, the shaded columns, which is the CLS column, has lower AT burden atrial tachyarrhythmia burden, whether in the initial follow-up or even at the later stage of the follow-up. Similarly, we do see, the concept in burden 2 studies as well. Patients were again randomized to these 3 different programming. One is CLS enabled, the other 2 are none. You do see again that those who actually on CLS enabled programming, it tends to do better in terms of reduction of the percentage of atrial tachyarrhythmia. So this is something that we do see in clinical trials as well, based on the concept. So, and of course, if you look at the duration of atrial tachyarrhythmia, you find that those who are actually on CLS programming, they tend to have a better in terms of a shorter duration of atrial tachyarrhythmia. So I think without doubt, based on the concept, based on the clinical trials, we do see the importance of using the CLS enabled pacemaker, especially in patients with the 6 sinus nodes, the 6 sinus syndrome with concomitant atrial tachyarrhythmia, because it actually prevents the onset of atrial fibrillation based on the concept itself. Of course, the mechanism, the real mechanism behind it, we need more further studies on it, but we really begin to get the gist of why it actually works. The other usage of clinical closed loop stimulation in clinical settings will be vasovagal syncope. And most of the time, patient who comes with vasovagal syncope, 60% of the time is actually neurally mediated syncope. Only 20% tends to be cardiogenic syncope, for instance, ventricular tachyarrhythmia and so forth. And that's why we tend to put patient on tilt table test. When we put patient on tilt table test, we have 3 types of response: type 1 response, type 2 response, and type 3. The type 3 is the one where they have drop of blood pressure way before or even without the absence of drop of heart rate. But the type 1 and type 2 is the one where you see the heart rate drop that contributes to the vasovagal syncope. And vasovagal syncope need not only necessarily happen in elderly patients, and it can actually happen in fairly young patients. I'm sure many of you would have experience of dealing with patients with vasovagal syncope. But again, the caveat here, the one important message here is, when you have a patient with very severe vasovagal syncope itself, of course, the first line treatment is not to jump in and put in a CLS pacemaker. Of course, we have to go along with lifestyle modification. We can try medications like fludrocortisone and things like that, but failing which we can no longer help that, then you may want to consider putting in a pacemaker for that cohort of patients who have very severe medically refractory vasovagal syncope, but provided they are considered type 1 or type 2 vasovagal syncope, not type 3. As illustrated in the ESC guideline over here, it's actually a class 2B indication. So if you have a tilt table test done on this cohort patient and you find that they do have a cardio inhibitory component and they are refractory, they are very disabled because of the vasovagal syncope, then you may want to consider to put in a pacemaker, but not just any pacemaker. It's actually a CLS capable pacemaker, and this is why it's going to be useful as well. So if you look at one of these studies over here, I'm just going to share with you these very small studies over here. Patients who actually had vasovagal syncope that is severe, almost 50 of them. The first year itself, they randomized them into 2 different arms. One is actually on CLS programmed, one is non-CLS programmed. All right. And on the second year itself, everyone becomes CLS programmed. So if you look at the graph over here, the first year itself, when they have patients who are actually on so-called non-CLS programming, you still have syncope happening. But whenever second years onwards, when everyone is already on CLS programming, you find that almost all of them actually has non-recurrences of syncope anymore. So this is actually telling you that the reasons of using a CLS algorithm in a patient with vasovagal syncope is because the moment they have vasovagal syncope setting in, the CLS will be able to utilize the algorithm itself to increase the pacing rate so that it will dampen down the cardio inhibitory component of the vasovagal syncope itself. So therefore, CLS really has its clinical role in the vasovagal syncope. And of course, the other studies that I'm just going to run through it will be the Spain study, which about 46 cohort of patients, both in group A and group B, initially on CLS algorithm, and the other one is initially not on CLS algorithm, and then they cross over after that. And again, you do see that those with CLS algorithm tends to have very significant reduction in terms of syncope because of the vasovagal response itself. So I think without doubt, whenever you look at AF itself or without, with patients with vasovagal syncope, the utilization of CLS algorithm in a pacemaker, in a dual chamber pacemaker, really helps in that context. And this is why I'm going to illustrate one of these cases to you. And this is a real life case that we actually done back then. It's a 52-year-old lady with pre-morbid NEU. Unfortunately, this lady has come with severe giddiness, vomiting, and then associated with palpitations, but there's no syncope as a point of contact at that point of time. Of course, workup in private hospital has many investigations done, cardiac MRI, so forth, choruses, and of course, a right heart cath. You can see that this patient had an ASD, mildly dilated, but has not come to a point where they have pulmonary hypertension yet. Holter done was just showing some proximal atrial flutter stroke fibrillation from the private hospital itself. So ECG at presentation, if everyone have a look at this, I think most of us will agree that the R interval is fairly irregular, but you do see some flutter wave very clearly, especially in the limb leads itself. Not so much in the V1 itself, but probably you see very clearly in the limb leads itself, you do see some flutter wave going on over here. So this is a patient with atrial flutter with variable block in this context, with the ASD, of course. Then, of course, we run the Holter for this patient, and true enough, we do see that the patient don't just only have a tachyarrhythmia issue, don't just only have a structural problems in terms of ASD. Patient also have a Brady issues. She has an intermittent sinus pause just when way surpasses the 6 seconds limit. This is a 7.3 seconds of a sinus pause. So this is really a patient, who had an issue with structural and rhythm issue. Transesophageal echo done showing a small secondum ASD, something that you can probably close in terms of percutaneous because the rims are fairly adequate. You do not really need an aortic rim itself for a percutaneous ASD closure. And of course, if you have a look at that, patient is still fairly someone with a left to right shunt. RA and RV mildly dilated, but these are patients who you want to do intervention at this point of time, not when they sets in the pulmonary hypertension itself. So to sort of sum it up, this is a patient with atrial tachyarrhythmia with Brady issues, at the same time structural in terms of ASD secondum, with a fairly normal mean pulmonary arterial pressure. So the first thing we always do to sort of do for EP study, get rid of the atrial tachyarrhythmia, because this is going to be a problematic, because we do know that atrial tachyarrhythmia, that is recurrence and symptomatic and it's very frequent. If we leave it alone, patient will get into tachy-induced cardiomyopathy, and this is something we do not want. So when we do the EP study and put patient on table for EP lab itself, we look at the intrinsic electrograms itself. We do know that this is a typical CTI dependent atrial flutter, and most patients of your atrial flutter will end up with a CTI dependent atrial flutter. It just basically means that patient had an atrial flutter that goes around the CTI, and this is really a cavo-tricuspid isthmus. This is usually a place where there's the thinnest area of the and tricuspid annulus with a lot of slow zone of conduction itself. And this is where we usually terminate the tachycardia. So this is where we usually do the ablations of terminate the tachycardia itself. And what really sort of reaffirms our findings of this patient really has the form of what we call a dysfunctional sinus node is whenever we pace the patient to try to terminate the atrial flutter, the patient had a long pause before the sinus node recovers. It just tells you this patient's sinus node recovery time is very long, not a very healthy sinus node disease, sinus node to begin with. So we ablated the atrial flutter, and of course the next thing to do is to close the ASD itself. All right, and this is done by one of our pediatric colleagues itself. And of course, the last but not least, the clean procedure is to put in a pacemaker because this patient really had a sinus nodal dysfunction. So the 6 sinus syndrome itself. And of course, we actually had the opportunity to use the CLS enabled pacemaker, EVR BIOTRONIK. So during the first post-implant check, 6 weeks later, this is something that caught us by surprise because if you look at here, the tracing upper here is from the atrial electrogram, from the atrial leads. The tracing lower down here is from the ventricular leads itself. And you do see that despite the V signals are very irregular, the A signals are very constant. This patient is having an atrial tachycardia coming back again. And this is very constant with variable block. So it means the AV nodes are not very great to begin with. That is why whenever you are trying to you have an atrial tachyarrhythmia going on, it doesn't conduct down constantly one-to-one. which is actually good in a way for this patient, because imagine if you have an atrial tachycardia that goes at almost a rate of 200 beats per minute conducting down, the patient may get very bad symptoms itself. The atrial tachyarrhythmia burden is almost 27%. Most of the pacemaker device will be able to tell you the atrial tachyarrhythmia burden. It means to say that 1/3 of the time patient is in atrial tachyarrhythmia. But the fact that the AV nodes are not that great, so it doesn't translate now 1-to-1 AV conduction. So this is not great, because it means to say that the AT is coming back again. But what we had is the patient was actually initially set, despite being a CLS enabled pacemaker, the programming initially was on the DDD-R, which is usually the usual dual chamber rate adaptive. It utilizes the open loop stimulation as a rate responsive instead of the closed loop stimulation. So again, patients are not very keen for procedure, having gone through 3 procedures from EP to ASD closure to, of course, pacemaker implant. Is understandable. So we decided, since this patient had a CLS capable pacemaker, why don't we turn on the CLS algorithm? And true enough, we turn on the CLS algorithm. So it means that this rate responsiveness of the pacemaker is now relying on a closed loop stimulation, no longer the crude, or what we call a more native form of open loop stimulation. So then we check the patient back in 6 weeks times. All right, this is the initial one, the first check itself. If you see the dark gray and the dark black column over here, it means that patient is still having atrial tachyarrhythmia. The moment we change it to the CLS algorithm in the pacemaker that is capable of it, we find that there is no longer atrial tachyarrhythmia. This is a histogram showing the atrial lead event. Basically, patient needs pacing. That is why it's the gray column over here. But patient does not have any sense atrial tachyarrhythmia anymore. And true enough, our atrial burden has come down to 0%. Just by tweak of a programming in the CLS capable pacemaker, we're able to prevent the recurrence or occurrences of atrial tachyarrhythmia. Now, of course, recent or subsequent check, this maintains at 0% in terms of the recurrences of atrial tachyarrhythmia burden. So the conclusion is that this patient had multiple problems, went through multiple procedures, had a recurrence of a lightly CPI-dependent atrial flutter. But the good thing is the patient had a CLS pacemaker on board, and we utilize that as a non-invasive intervention to prevent the onset of occurrences of recurrences of atrial flutter. So this really helps in the long run for these patients. So the take-home message over here is that I hope over the past half an hour or so, we do have understand what is the rate adaptive mechanism that we have. One is the open loop system, which is available in most pacemakers. One is a closed loop system, which mimics near physiological response, which is available in the CLS capable BIOTRONIK pacemaker. And only CLS capable pacemaker allows you to have mental as well as also physical input that will bring towards nearer physiological rate responsive adaptation in increasing the pacing rate. And of course, we do see from several papers that CLS algorithm can be utilized in patients with concomitant sick sinus syndrome with atrial tachyarrhythmia, and also in patients who is actually having refractory severe vasovagal syncope, which has a cardio-inhibitory response. We're talking about patients with tilt table response of type 1 or type 2, whether it's 2A or 2B. With that, thank you. I'm happy to answer any questions if you do have.
Good day, Dr. Giri. Can you hear me?
Yeah, I can. Hi, Kanta. Hi, nice to have you back from.
Yeah, thanks. Nice to hear you too. How are you?
Yeah.
Good. I have one question. I have one question. You nicely demonstrated the atrial flutter on a CP study. Did you apply the case?
We did the first time round before. In fact, the first time round we de-ablated the patient, then went for ASD closure, then went for pacemaker implant. But unfortunately, when she had a recurrence of atrial flutter, she's not keen for re-ablation because of so many procedures she has went through. So she's a bit kind of upset to go through another procedure per se.
Despite ablating, despite ablating the atrial flutter at the recurrence, so you choose CLS because you think that the possibility of AF infection is still there, or for any other reason?
I think that's because we do treat that, because she has ASD, and then the fact that she has structural abnormalities and things like that, we do worry that there may come a time she may have a recurrence of either a recurrence of the ablated CDI dependent flutter, or she may have a onset of another form of flutter, a scar flutter or things like that. So because of that, we decided we may utilize the CLS algorithm pacemaker instead. And true enough, our decision was right, because when she had that recurrence, we can utilize it instead of going for a re-ablation. The worst thing is, if we have to cross over through the ASD closure device to get into the left side to do an ablation. That's the one we do not really want.
Thank you so much. Nice talking to you again.
All right, thanks. Oh, we can meet someday later.
Sure, yes, thanks.
Yeah, Chi has a question here. For the EGM that detected the atrial flutter, how to differentiate atrial flutter, AT from atrial flutter? Well, generally speaking, if we are talking about atrial tachycardia, atrial tachycardia is a big word, it's a big group. Of course, atrial tachycardia can include atrial flutter. We can talk about CDI dependent, non-CDI dependent, and so forth. But when we're talking about atrial flutter per se, we're usually more talking about focal atrial flutter. It comes on one nice spot. And most of the time, focal atrial flutter, it tends to be more wobbly. It means to say that if I were to measure the AA intervals, that means when I look at the intrinsic AA intervals, the intrinsic electrograms, the AA intervals are very wobbly. When it wobbles about 10 to 20 milliseconds, because the focal atrial tach is usually a site, a very localized site, which fires automatically. And this automaticity are usually very so-called unpredictable. So it tends to wobble a bit. Whereas the atrial flutter, which is actually most of the time tends to be a circuit itself. So whenever there's a re-entrant circuit, the A to A interval tends to be more constant because the circuit is very fixed. Whereas a focus that is firing automatically tends to be more abnormal and tends to be very more erratic. That's why it's a bit wobbly. So that's how we look at it. And of course, CDI dependent flutter, what we really look at is we look at how the activation pattern looks like. Of course, it's beyond the scope of today's talk, and I do not have the slide to illustrate also. But sort of we can see that the activation really goes around from top to bottom, and then from the lateral wall to the septal wall itself. But of course, I'm sure that we will be able to organize some live webinars on the atrial flutter together with our nice EP Sedam team as well. I hope I answered that question, Achi. Haoni looks good with all the cute nurses. Yeah, that's one of the plus points of working in the private sector. Good. For AT with non-adrenergic driven in the presence of 6 silence, do you think CLS mode will help in treating AT? Yeah, certainly, CLS algorithm in terms of atrial tachyarrhythmia, there's always a limitations, especially when you're talking about non-adrenergic driven. But I still believe that, whether is it driven by sympathetic overdrive or not in terms of atrial tachyarrhythmia. So, but the sheer fact that whenever there is any form of tachyarrhythmia, there will be increments in terms of the RV impedance. That will actually helps to utilize the CLS algorithm, and that of course will actually translate. But in terms of preventing the recurrences and all this, I think that's really, your guess is as good as my guess. I really have no answer for that until we have a large trial looking at a large number of patients and we can utilize the EP findings and correlating with the pacemaker findings. Then only we can really answer that.
Thank you, Dr. Gary, and all of you for your participation in this educational live webinar brought to you by BIOTRONIK. See you next time.